welcome. This is another episode of the NAS podcast. We are here assembled at the 2025 annual meeting for the North American Spine Society, our 40th anniversary celebration, and we've assembled a great panel to discuss a very hot topic in spine surgery, which is endoscopy. Of course, doing a complete, fully comprehensive review of endoscopy is beyond the scope of a podcast, but for the next 15 to 20 minutes, we're going to discuss what's really on the minds of surgeons and whether endoscopy is worth bringing into your practice. So I'm Stephen Pirris. I am an Associate Professor of Neurosurgery at the Mayo Clinic in Jacksonville and the co-chair of the NAS section on robotics, enabling technologies, and minimally invasive surgery. And I'm here joined by
Nathaniel Brooks. I'm a professor of neurosurgery, University of Wisconsin, Wisconsin.
I'm Karthik Madhavan. I'm an assistant professor at Cooper University Healthcare in Cherry Hill, New Jersey.
And my name is Ernest Braxton. I'm a neurosurgeon in private practice in Vail, Colorado.
So we're going to take a few minutes for each of us to give kind of their thoughts on endoscopy, and then we're going to have a roundtable discussion. So why don't we start with you, Dr. Brooks?
I've been doing endoscopic procedures for about 8 years, so I have incorporated in my practice basically a long time ago, long before it was really common to be discussed, and I've found a good niche for it, and I use it regularly.
Very good. And I'm Dr. Pirris, and I actually started endoscopy about 15 years into my practice, and so I'm kind of the viewpoint that even old people, old dogs can learn a few new tricks. And I think there is definitely a value for it in selected cases.
So with me it is a little bit different, and I started my training in endoscopy during my residency, and after that I had a long pause because we just could not get it approved. And now that we have approved, I just started about 8 to 10 cases.
I was exposed to endoscopy in residency and used it fairly regularly while I was during military service. But when I started my private practice in Vail, ended up giving it up.
Okay, so a couple thoughts. We have a couple questions for the group. So what do you all think is the minimum training necessary to start performing endoscopic spine surgery?
I guess I'll start. I think that that you do have to spend some time. If you're learning as a practicing surgeon, you don't really have a great way to have a mentored experience. So you do have to spend some time gaining the technical skills, which is in labs, and that's just simply learning how to manipulate the tools, how the visualization works, those kinds of things, and then from there, using simulators, cadaveric models, those kinds of things can be very helpful, and generally, we're thinking about spending at least 2, maybe 3 labs trying to get those skills before you start.
Okay, I strongly believe that endoscopy should be a part of your residency. The reason I say that is, let's say for example, now every patient in New Jersey who comes to me, they are like, hey, do you do endoscope or do you do laser? Those are the 2 things that I get asked commonly. And now, if I don't do it, and if there is a competition where in a place like Cherry Hill, which is very competitive, it's really, if you want to stand out completely from the other guys and offer something very different and niche, I think that really helps. And if you have a training in residency, you can start right off the bat in your practice and don't have to wait for more training.
I think we have to establish what is endoscopy, because there's a lot of different forms. I think if you're doing very traditional uniportal endoscopy, working through a fluid medium with a working channel that's through the scope, that's a much steeper learning curve. And I do feel sorry for those patients that need to go through that learning curve. I think if you're using biportal, again in a fluid medium, I think that the learning curve is a little bit less, maybe fewer cases, maybe 20 cases or so. And then there's a form of endoscopy where you're working just through an air channel and using it as a medium for magnification and illumination. It's very similar to a microscope. I think that's a pretty flat learning curve.
Okay. And I take the approach of, for the mid-career and late-career surgeons, I think there is actually an advantage to starting endoscopy later in your career because you are so familiar with that anatomy. Just like whenever I trained as a very open spine surgeon, which helped me become a better minimally invasive surgeon, which then therefore helped me be a better endoscopic surgeon because we're more familiar with the anatomy, and I think that surgical training is key. Another question is for coding and billing. Again, I'll start with you, Dr.
Can I make
Oh,
a
yeah.
quick comment? Just what I saw. Of course, I was kind of in the very early phases. There weren't many people to mentor. Now we have it within our residency, and then of course in our fellowship. And so the jumping off point for that group of trainees is dramatically different than where I started. And so I started and I kept it very basic. Very much thought about the concept of, can I do this operation? If I need to convert it to an open operation, just put a tubular retractor down and do it microscopically. That's kind of where I was when I started. But with the residents and the fellows, they've already seen it. They can see what the tools do. And so you're right. I mean, it's going to be much better off if you have it within a residency training environment. And I think what we're all going to be talking about today is there value to putting it in a residency, number one, and number two is what happens once you get to your first job, right?
Yeah.
Like what happened to you?
So
Yeah.
in my first job, I was practicing in Fargo, North Dakota. So I was a hospital employee. The good thing about practicing in Fargo, North Dakota was we had only 11 surgeons for the whole state. So I really didn't have to work anyway to get patients in my clinic. They just showed up. So when I moved there from New Jersey, because it was so cold, so now Cherry Hill is extremely competitive, and there are about although the population is much higher, the number of spine surgeons are also in much bigger number in proportion to the population. So I had to convince my administrators that we have to stand out and offer something completely different. So that's where endoscopy came in. And I, believe it or not, I first did my biportal first before my uniportal because it was such an easy learning curve, like you mentioned. So said that, now that we have, I'm just about 10 cases old now, and we have sent out a blast of emails to all the private practice guys and so forth, and now we have to see how that reciprocates in getting more patients into the room.
And so with that in mind, so your hospital obviously was making decisions over the last several years that they're going to want to pay for a different product or a different capital purchase instead of endoscopy. So what were some of the discussions between you and your partners trying to advocate for endoscopy to the hospital, and what were some of their reservations?
This was, the main thing was, first we wanted to show them that endoscopy works. So that's why I started doing the biportal. And once I told them, I had literally a patient come and talk to one of the administrators saying that where I did a lumbar 4-5 with a micro disc like about 9 months ago, and then he had a L5S1 biportal on the opposite side. And when he came and talked to the administrator, he said, this time my pain was 90% better than what it was before. And that kind of opened up the mind for them, saying that, okay, endoscopy works. It's not some gimmick, or it's not going to fade away or something like that. Because in the past, every time the hospital, invests in a surgeon, and let's say they leave and go, and the new surgeon comes in, he may not like the same technology. He may not use it. Mm-hmm. So that's why I had to show them that this really works, and this really is here to stay.
Well, I was first exposed to endoscopy by Haedong Joe in Pittsburgh, and then later did some courses with Tony Young. And Tony Young always emphasized, for the purpose of safety, the patient should be awake, because there is a risk of injuring a nerve root, excessive retraction during the endoscopic procedure. I really liked that aspect, and I thought that was the reason that the patients seemed to do so well, at least in the hyperacute recovery phase, is that they didn't have a general anesthetic. So I started doing awake patients and applying more regional anesthesia to more traditional MIS tubular cases. And I found that the diminished muscle disruption you get in endoscopy, I think, is a little bit overstated. I think we've really kind of, using tubular techniques, have really minimized muscle dissection for these cases, and there's less retraction, and it's a safer environment for the patient. And that's one of the reasons why I've, just for the safety and practicality, I've gone back to tubular MIS.
And I think when I feel similarly, like I'll tell the residents, and patients, especially as we talk about coding, if your insurance company won't pay for this and we have to do a tubular lumbar discectomy, it's going to be pretty much the same, right? So I don't overstate the benefits of endoscopy for lumbar pathology, but as you get into thoracic and cervical, you start to see a drastic difference in what you can do and then what the recoveries are going to be like compared to the comparator operation is just different, right? So you're either doing something that's retropleural transthoracic or costotransversectomy with a fusion, or potentially, it just depending on the anatomy of the disc, having to do something a lot more complex. But with the endoscope, you can do it in a more directed fashion. Studying our comparator groups, we have an abstract that we're presenting here at NASS, just looking at posterior cervical foraminotomy. If you look at those patient groups, we see a big difference in like their narcotic utilization and things like that post-operatively. So their recovery curve seems to be faster compared to a tubular approach, but you wouldn't necessarily see the same thing in the lumbar spine. So it's just,
Can I just slightly disagree with that? So, I mean, we're doing, tubular posterior cervical foraminotomies with like a 14 millimeter or sometimes a 16 millimeter tube, discharging them the same day,
right.
Often using like newer post-operative pain medications like Gervonix and avoiding narcotics in those guys. And my concern in the cervical spine is the introduction of the fluid medium if there's an unrecognized durotomy increasing ICP. And being able to handle that in a surgery center can be quite challenging.
Right.
So I prefer the more conventional method of using the microscope, but still creating a very small access channel with a albeit larger tube, like a 14 millimeter
right.
tube as opposed to an 8 millimeter tube, but not introducing the fluid medium and the possibility of elevating ICP.
Right, and I think that's a good point. You have to manage the fluid in endoscopy, part of the learning curve, and it has to be a very carefully done. Of course, knowing that we do interventricular operations with fluid flowing inside the brain all the time, I don't think we have to be as worried about that as we sometimes are. So having a durotomy in a cervical or lumbar endoscopy, I don't think is going to elevate the pressure any higher than if you were doing an interventricular operation and taking out a colloid cyst or something like that. Yeah.
Again, but you're in a more prepared setting. You're not in an outpatient setting. You're in a hospital doing
right.
interventricular work. You have an ICU available, and oftentimes you may even leave an external ventricular drain
right.
to manage ICP afterwards.
So I think that's an important point. Situationally,
Yeah.
it matters a lot, like where you're at.
Right.
If you don't have these resources, you certainly have to think about these things and whether or not that risk profile is going to fit your practice.
But I
yeah.
totally concede endoscopic thoracic disc is probably the best utilization, although that's not a very common thing that I see in my practice.
Right.
It's far superior to, I think, in terms of patient recovery to the retropleural fusion approaches or the larger costotransversectomy approaches. That's a great use for endoscopic.
Yeah, and I've seen it essentially, in trying to train the residents on indications and things like that. I certainly do not think that everything should be viewed from an endoscopic lens and be done endoscopically. Even when you look at things like lumbar laminectomies, once you start to get into more than one level, the time component and the anesthesia component is so much higher that sometimes the value just kind of dwindles at that point. So you have all these different things where it might be beneficial in one situation and not very beneficial in the other. So.
Yeah. So, now that you mentioned about the training, I really wanted to, this is how I think about endoscopy versus open versus MIS. Let's say, for example, you're looking at a building at a bird's eye view and your access point is the northeast 5th floor window, right? So when you're looking at like a bird's eye view, you can easily point out that's where it is. And now for MIS, you're almost like 10 feet from the building. And now you have to point out where it is. So you have to know the anatomy, know the building very well to know exactly where it is. For an endoscopy, you're almost like 1 feet away from the building. Right. You just have to understand like what you're looking at and where is the northeast 5th window, where you have to access. So once you understand that, the understanding comes from your depth of anatomy knowledge, and that's where the training comes in place. And a lot of people like Steve have picked it up because their anatomy was very strong.
And again, just to kind of rehash, we're going to, start putting about, I will hit a couple points. I think training is going to be super important. Our next generation is going to need to do endoscopy. They're going to want to do endoscopy. I think that's going to be a part of all of our training. Even for those who have been out in the world for a long time, I think to circle back to your point, if you start a case and you're not comfortable, just drop a tube in and you can make it a hybrid case. And that's how I started my first 10 cases. I did them hybrid. I did partially minimally invasive, partially endoscopy, and then transitioned to full endoscopy. And then to your point, you have to be what is comfortable and what you think is safest for the patient, because at the end of the day, we're trying to help the patient. But this is a fantastic discussion, and thank you all for being here, and I think the NAS community will benefit from this.
Thanks for having me.
Thank you very much. Thanks for everybody for coming and talking about this. Yeah.